Now the second topic, which is the aggressive periodontitis, which is done by Mr. Mohammad Mohammad, third year student at Al University.
Assalamu alaikum wa rahmatullah. Good morning, everybody. It's my pleasure to be with you today. I'm a third year dentistry student at Al University. I'm going to talk about aggressive periodontitis. Aggressive periodontitis, a multifactorial, severe, and rapidly progressive form of periodontitis, characterized by destruction of alveolar bone and periodontal attachment loss over a short period. Differences between aggressive periodontitis and chronic periodontitis: it's the age of onset, rapid rate of disease progression, nature and composition of the associated subgingival microflora, alteration of host immune response, and familial aggregation of diseased individuals. Risk factors of aggressive periodontitis are microbiological factors: Actinobacillus, Actinomycetum comitans, and Cabinocytes phage species. Immunologic factors: functional defects of polymorphonuclear leukocytes or monocytes, altered helper or suppressor T cells function, polyclonal activation of B cells by microbial plaque. Autoimmunity has a role in generalized aggressive periodontitis. Host antibodies to collagen, DNA, and immunoglobulin G. Genetic factors result from several studies support the concept that all individuals are not equally susceptible to aggressive periodontitis. Environmental factors: the amount and duration of smoking are important variables that can influence the extent of destruction. Aggressive periodontitis can be classified into two main groups. The first one, localized aggressive periodontitis. The second one, which is generalized aggressive periodontitis. The clinical characteristic of localized aggressive periodontitis: age of onset at about puberty, localized to first molars and incisors, presentation with interproximal attachment loss of at least 2 permanent teeth, minimal amount of plaque, advanced bone loss, presence of deep periodontal pockets, increased mobility of maxillary and mandibular first molars and incisor, flaring of anterior teeth, periodontal abscesses, and lymph nodes enlargements. As we can see here, it's localized to the incisors area. Radiographic findings: vertical loss of alveolar bone around first molars and incisors, arc-shaped loss of alveolar bone extending from the distal surface of the second premolar to the mesial surface of the second molar. It's localized to the incisors area and the first molars. This is an arc-shaped of loss. The second part, generalized aggressive periodontitis. The clinical characteristic usually affects individuals under age of 30. However, older patients may also be affected. Generalized interproximal attachment loss, affecting at least 3 permanent teeth other than first molars and incisors. The destruction appears to occur episodically, minimal amount of plaque, severely inflamed gingival tissues, ulceration, and bleeding may occur spontaneously. This is a generalized aggressive periodontitis. Radiographic findings can range from severe bone loss associated with minimal number of teeth to advanced bone loss affecting the majority of teeth in the dentition. It's generalized to all of dentition. Treatment options for aggressive periodontitis: non-surgical phase of treatment and surgical phase of treatment. A non-surgical phase of treatment can be combined between mechanical therapy and antibiotic therapy. Mechanical therapy, scaling and root planing, which eliminates the microbial bacterial load from the periodontal pockets. Antibiotic therapy, doxycycline, 200 milligram first day, then 100 milligram per day for 2 to 3 weeks. Metronidazole, 500 milligram 3 times per day for a week. Metronidazole and amoxicillin, 250 milligram. Metronidazole plus 250 milligrams of amoxicillin 3 times daily for a week. The surgical phase of treatment: bone replacement grafts. Bone grafting is indicated for treatment of aggressive periodontitis. Guided tissue regeneration also indicated. It promotes regeneration by acting as a barrier which prevents apical migration of epithelium and excludes gingival epithelium from the healing wounds. That's allowing the periodontal progenitor cells to establish new cementum and attachment. That is my reference. Thank you for listening and attention.
Thank you very much, and it's been very nice to listen to you because I saw you as first student in Jove,
Yes.
but mashallah, now you are very confident.
Thank you, Doctor.
Congratulations. But my only comment is, again, related to the first lecture of this session, that please, we should come out of this dentistry alone. We should look at the diseases from systemic point of view as well. So nowadays, there's a lot of research showing that there's a link between periodontitis and systemic diseases, like diabetes, like cardiovascular disease, right? Low baby birth weight. All these are related to periodontitis. So we should be broadening our vision to include all this in our knowledge. And that is my request to all of you today. Thank you very much.
Thank you. Welcome.
Any questions from the dental students? Yes, go ahead.
Thank you very much. I like that you were able to manage in a short time to give an overview of aggressive periodontitis from etiology to pathogenesis to management. Very, very nice. Just a little bit of update. You mentioned the name of the bacteria, Actinobacillus actinomycetum comitans.
Yes.
The name of this bacteria has been changed 10 years before to Aggregatobacter actinomycetum comitans. And with the generalized form of aggressive periodontitis, Performonas gingivalis and fusobacteria are also important. That's why we give metronidazole for generalized forms. Thank you.
Thank you. Welcome.
Thank you, Mr. Mohammed.
Thank you again. For more explanation, visit this hashtag, aggressive periodontitis. Thank you.